Let's begin neurology and special senses. First, embryology. So, in the neural development, you know that the notochord in the adults is converted into nucleus pulposus, and the ectoderm forms a neural plate in adults. And this neural plate gives rise to neural tube and neural crest cells. So, from the neural tube, you get all this brain and spinal cord. From the neural crest cells, you get in peripheral, you get squam cells and satellite cells. In central nervous system, you get oligodendrocytes and also you get astrocytes. So now the main thing is the lateral walls. The lateral walls of the neural tube are divided into alar and basal plates of spinal cord. We know that the alar plates are dorsal, they are sensory, whereas the basal plates are ventral and they are motor. So coming to the regionalization of neural tube, the neural tube is divided into prosencephalon, mesencephalon and rhombencephalon. Prosencephalon is the forebrain, which is in turn divided into telencephalon and diencephalon. And the outer surface of telencephalon forms the cerebral hemisphere and basal ganglia, whereas the inner cavity forms the lateral ventricle. And for the diencephalon, the outer layer forms the thalamus, hypothalamus, retina, and the inner cavity forms the third ventricle. And the mesencephalon outer layer forms the midbrain, and the inner layer, that is the inner cavity, is cerebral aqueduct. Coming to the rhombencephalon, in the rhombencephalon, it is again divided into metencephalon and myencephalon, and inside the cavity is forming the upper part of fourth ventricle and the lower part of fourth ventricle, whereas the metencephalon is divided into pons, cerebellum, myelencephalon is divided into medulla, and of course this neural tube continues with the spinal cord. So this is the just basic. Now coming to the peripheral and central nervous system, we know that the neural crest cells form the astrocytes and oligodendrocytes in the central nervous system, whereas the satellites, squam cells, all these are formed from the neural crest in the peripheral nervous system. Very important thing is that the mesoderm can form the microglia cells. Microglia are nothing but the macrophages of the central nervous system. Now let us come to neural tube defects. Neural tube actually starts closing by a fourth week of development in baby. So if it is failing to close in the fourth week, then you can check the amniotic fluid of the mother. Then if you see high alpha fetoprotein, then you can think of this neural tube defects. But remember, in spina bifida occulta, the alpha fetoprotein will be normal. And the confirmatory test for this neural tube that which is not closed is increase in acetylcholinesterase. And the next one, spina bifida occulta, means closure of spinal cord, which is not happening in the caudal part. So because of that, you'll get some pimple, some hair like tuft cells, all those are visible. Next, coming to meningocele. In the name itself, you can see meningocele means the meninges are coming out from that unclosed part of neural tube. Myelomeningocele means spinal cord and also the meninges layers. You know the meningeal layers, pneumonicus pad, pia mater, arachnoid mater, dura mater, okay, from inner to outside. So those meninges and also the spinal cord comes in myelomeningocele. Myeloschisis is the problem where directly without any meninges the spinal cord comes out from the open neural tube. Myeloschisis is that one. Next, coming to anencephaly. Anencephaly, the thing which you need to see is here all the neural tubes are open on caudal side, but anencephaly, the neural tube is open on the starting point in the beginning. Failure of rostral neuropore to close. So here the clinical findings will be, as the baby, we know that the baby's amniotic fluid is coming from the urine of the baby itself. So here in the anencephaly there is no formation of forebrain, all structures, so that the baby is unable to again swallow that amniotic fluid. So there will be polyhydramnios, excess amniotic fluid, because no swallowing center is in the brain because of anencephaly problem. Now coming to brain malformations, they are of two types, holoprosencephaly and lysencephaly. Holoprosen, in the name itself you can understand it's like a whole brain. That is, this brain is not dividing into cerebral hemispheres and it is having only the single ventricle, that is the monoventricle is present in this brain. And these patients have the problem of mutations HH, and also they may be associated with Patau syndrome, fetal alcohol syndrome, and this mainly presents with monoventricle and also fused basal ganglia, cleft lip, cleft palate, hypotelorism, cyclopia, proboscis, and there's also increased risk of pituitary dysfunction, especially holoprosencephaly people may get diabetes insipidus. Now coming to lesioncephaly is a problem where there is no gyri and sulci in the brain, so the brain appears like a smooth surface. Okay, so failure of neuronal migration, especially the problem is failure of radial migration. So this is associated with microcephaly, that is a small head, and facial anomalies, and also hydrocephalus. Now coming to posterior fossa malformations. So here you have Chiari 1, Chiari 2, Dandy Walker. In Chiari 1, the name itself you can see 1 means only the cerebellar tonsil has come out from the foramen magnum. This one you can see Chiari 1. In Chiari 2, the problem is two structures have come out. That is, you can see here two means the two structures are you got cerebellum and also got medulla. Okay, both are coming out from the foramen magnum. And one more thing, Chiari 1 is associated with syringomyelia. What is syringomyelia? I'll say next. And Chiari 2 is associated with meningomyelocele. How to remember their associations? Chiari 2, two structures are coming out. Even in meningomyelocele, meninges are coming out, and even the spinal cord is coming out. Now coming to Dandy Walker malformation. Here the problem is the cerebellar vermis is not formed. As the vermis is not formed, this enlargement of fourth ventricle. Why vermis is not formed and why fourth ventricle is enlarging? Because if you remember, in the neural tube, the cerebellum is coming from the rhombencephalon. So as there's a problem with the rhombencephalon, especially vermis formation, so the fourth ventricle is getting enlarged. Now coming to syringomyelia, here the problem is there's a cyst which is formed in the spinal cord, and the cyst is leading to blockage of especially pain and temperature, that is the anterior fibers which carry pain and temperature to upper extremities. So if there's a cyst here in the white fibers, this person can't feel the pain and temperature, especially in their upper extremities. And this syringomyelia can also go towards the lateral side of the spinal cord. If this cyst enlarges to the lateral side, it may cause Horner syndrome. In Horner syndrome, there's ptosis, meiosis, and anhidrosis. Now coming to the tongue development. Tongue is divided into anterior 2/3 and posterior 1/3. Anterior 2/3 of the tongue is mainly supplied, the taste is by cranial nerve 7 and the sense is by cranial nerve 5, third branch, trigeminal third branch. Okay, so how I remember this is taste is by bigger number and sensation is by lower number, because in posterior 1/3 of the tongue also the taste is mainly by 9 and the sensation is by 9 and the taste is by 10, so bigger number tasty. So here 10 gives the taste to the tongue in the posterior 1/3, here 7 gives the taste to the tongue in anterior 2/3, whereas the sensation for the anterior 2/3 is by cranial nerve 5 and the sensation for posterior 1/3 is cranial nerve 9. And there are different muscles which are getting motor innervation by cranial nerve 12, that is hyoglossus which retracts and depresses trunk, genioglossus which protrudes the trunk, styloglossus which draws the tongue towards the sides. So these three muscles, hyoglossus, genioglossus, styloglossus, are supplied by cranial nerve 12, whereas cranial nerve 10 supplies to palatoglossus, which is useful for swallowing. So swallowing, palatoglossus 10, and also 10, if you remember, it's giving sense taste to the posterior 1/3. Okay, so now coming to this basic anatomy of neurons. Neurons are, we know they are the permanent cells and they are signal transmitting cells. We know basic dendrite receives the input and axon sends the output. Important thing, rough endoplasmic reticulum is not present in axon. And the neuron markers are very important, neurofilament protein and synaptophysin. Now coming to astrocytes. Astrocytes are the glial cells, most common glial cells in the central nervous system. But as our glial cell, don't think they are derived from mesoderm, they are derived from neurocytes, that is from the crest cells. And their marker is GFAP. And these markers you can see in the tumors of astrocytes. In adults it's glioblastoma, in children it's pilocytic astrocytoma. There if you find this GFAP positive, then you can confirm this cancers. And here there's a problem of astrocytes give physical support to neurons. They help to repair any problem in neuron, or they remove excess neurotransmitter, and it is also part of blood-brain barrier. It also gives glycogen whenever energy is less, and there is a reactive gliosis in response to neuronal injury. Now coming to microglia. Microglia is derived from mesoderm. It's a macrophage. Important thing is it also releases inflammatory mediators. One more thing, HIV infected microglia fuse to form multinucleated giant cells. Especially, it is associated with HIV dementia. In HIV patients, there's dementia because of these microglial cells which are reactive and they are forming the giant cells in the central nervous system. Now coming to ependymal cells, we know ependymal cells line the ventricles. So if these ependymal cells are specialized like choroid plexus, then they produce a CSF, and these ependymal cells are having cilia and microcilia. Remember, cilia is for the movement of CSF, microcilia is for the absorption of the CSF. Now coming to myelin, we know myelin, it's wrapping our neurons either in central nervous system or in peripheral nervous system. In central nervous system, it's done by oligodendrocytes. In peripheral nervous system, by Schwann cells. One more thing, by myelin is required is for the saltatory conduction. What is the saltatory conduction? Because of myelin, actually the signals jump from one node of Ranvier to another node of Ranvier. And one more thing, the node of Ranvier is rich in sodium channels. Okay, voltage gated sodium channels. So let us see Schwann cells, we know in peripheral nervous system, but important, Schwann cell only can myelinate one peripheral nervous system axon. It is injured in Guillain-Barré syndrome, which is a peripheral nervous system disease. Here the Schwann cell marker is S100. Okay. Now coming to oligodendrocyte, it can wrap around 30 neurons, 30 axons. It is a predominant type of glial cell, and its appearance is like fried egg pattern in histology. Okay. Now coming to neuron action potential. Neuron action potential is very simple. First, it's in resting potential, okay, where its potassium channel is open. With potassium, it's resting. Next threshold, we know depolarization, where sodium channels are open and sodium is entering into the cell. And next it comes to repolarization, where potassium channel is open and potassium is going out from the cell. And finally comes to fourth phase, that is hyperpolarization, where potassium goes extremely out, and this is the phase of hyperpolarization. So resting potential, threshold or depolarization, repolarization, hyperpolarization. Now coming to sensory receptors. Actually, we have free nerve endings. These are useful for pain and temperature. They are divided into two types. A delta is fast because it's myelinated. C is slow because it's unmyelinated. Now coming to Meissner's corpuscles. They are large myelinated fibers and they adapt quickly. They are present in glabrous skin, like hairless skin, and this is useful for fine touch, light, and skin identification. Now coming to Pacinian. I remember Pacinian like Pacific Ocean, which is deep Pacific Ocean for the deep skin layers, ligaments, for especially vibration, deep vibration and pressure. These are also large myelinated, adapt quickly. Whereas Merkel discs are large myelinated, but they adapt slowly. They are present in our fingertips, superficial skin. They are also for pressure and deep static touch, like to appreciate the shape of an object or edges of an object, like that. Ruffini corpuscles are large myelinated. They are also in fingertips and joints. They are for stretch and joint angle change. Now coming to peripheral nerve. So peripheral nerve, inside it is lined by endoneurium, outside middle by perineurium. That is, perineurium actually covers a fascicle, and finally outer is epineurium. Now coming to chromatolysis. Here the problem is whenever there's an injury to the nerve, at the site of damage nothing happens, but beside the site of damage there is a problem called as Wallerian degeneration, and here the microglia comes and eat all the debris away, and the site which is before the site of damage is called axonal retraction, and here undergoes chromatolysis, where the cell is completely filled with extra proteins and fluid edema, and this pushes the nucleus to the periphery, and this is called chromatolysis. Now coming to neurotransmitters. Acetylcholine is located in the basal nucleus of Maynard, that is forebrain, and this acetylcholine is decreased in Alzheimer's disease, decreased in Huntington disease, but it is raised in Parkinson disease. Very important. Alzheimer's low acetylcholine, Parkinson high acetylcholine. Dopamine location is ventral tegmentum of midbrain. It is low in depression, high in schizophrenia, and also high in Huntington, but low in Parkinson. Now coming to GABA. GABA is from nucleus accumbens, that is the basal ganglia. It is low in anxiety and low in Huntington disease. Norepinephrine is released from locus coeruleus pons. It is high in anxiety, low in depression. Next coming to serotonin. Serotonin is released from raphe nuclei of brainstem. It is low in anxiety and low in depression. Now already we know meninges pia, arachnoid, dura. Dura is outermost layer, it is derived from mesoderm, whereas arachnoid and pia both are derived from neural crystals. And we know that CSF flows in subarachnoid space, that is below arachnoid space, nothing but between arachnoid and pia mater. And epidural space, it's a space between the dura mater and the skull, so there we have the bridging veins, and especially we have middle meningeal artery. So whenever middle meningeal artery is injured, then you should think of epidural hemorrhage. Now coming to blood-brain barrier. Blood-brain barrier is actually made up of four structures, that is tight endothelial junctions, basement membrane, pericytes and astrocytes. So these are the four contents of the blood-brain barrier. Why it is made is to avoid unnecessary things to enter the brain. But there are some organs called circumventricular organs which usually don't have blood-brain barrier. That is area prostrema, which is vomiting center, and OVLT, which is organum vasculosum lamina terminalis, which is osmoreceptor. So both of these don't have blood-brain barrier. But sometimes the blood-brain barrier may disrupt, like in stroke, and by using hyperosmolar agents like mannitol may break the blood-brain barrier, and we do this to increase the permeability of medication to brain. Now coming to vomiting center is mainly activated by nucleus tractus solitarius in medulla, and this receives information from chemoreceptor trigger zone, and this is located within area prostrema. So like this gets activated from GI tract, it gets activated by vagus nerve or vestibular system, also from CNS. So after all this activation, there are 5 major receptors like histamine, muscarinic, neurokinin, dopamine and serotonin. They receive the input and they lead to vomiting. So we use treatment like serotonin, dopamine, NK1 and antagonists. We use antagonists so that we can prevent vomiting. So we treat chemotherapy induced vomiting. H1 and M1 antagonists mainly used to treat motion sickness. H1 antagonists treat hyperemesis gravidarum and pregnancy. Now let's see sleep physiology. Sleep physiology, our sleep cycle is controlled by circadian rhythm, especially our pineal gland, and there's a nucleus called suprachiasmatic nucleus of hypothalamus which activates the sleep cycle. So mainly the suprachiasmatic nucleus first activates and release norepinephrine, and that will activate the pineal gland, and melatonin releases from the pineal gland, so we get sleep. So our sleep is divided in two types: rapid eye movement and non-rapid eye movement, that is REM and non-REM. Alcohol, benzodiazepine, barbiturates decrease REM sleep and also N3 sleep of non-REM. Norepinephrine also decrease REM sleep. Benzodiazepines are useful for night terrors and sleepwalking, because we do sleepwalking in N3, that is non-REM sleep, and also REM sleep can be decreased by benzodiazepines. So let's see some graphs EEG waveforms. When you sleep with your eyes open, that is having beta wave on EEG, and when you are awake and your eyes are closed, you have alpha waves. Non-REM sleep is divided N1, N2, N3. N1 is just light sleep, so you have theta. N2 is deep sleep, and this bruxism going on, that is sleep spindles and K complexes. N3 is deepest non-REM sleep, so it is deepest, so D for D delta. Here you do sleepwalking, night terrors, bedwetting, etc. Now coming to REM sleep. REM sleep is where you lose the motor tone and you have variable blood pressure, acetylcholine. REM is where you have dreams, nightmares, and memory processing. All this occurs here, and here you can see beta waves. Okay. Now coming to hypothalamus. Hypothalamus is related to thirst, water balance, controlling anterior pituitary, posterior pituitary, and hunger, autonomic nervous system, temperature, sexual urges, all are controlled by hypothalamus. So there are different nuclei in hypothalamus. Let us see each of its function. Lateral nucleus is for hunger destruction, because here there's a anorexia because it is stimulated by ghrelin. Lateral nucleus, our stomach feels like it's full because of ghrelin, so these people don't eat much and they become anorexia, like very thin, and it's very hard to thrive in infants. Next, ventromedial nucleus, there's satiety, that is a feeling of fullness because of increase not fullness, this destruction. So ventromedial nucleus is for satiety, but if it get distracted, then there will be hyperphagia because of leptin. So leptin is like eat more, so they'll eat more and become more fat. And ventromedial nucleus. Next, anterior nucleus is for cooling, parasympathetic. Posterior nucleus is for heating, sympathetic. Suprachiasmatic, we already know, for sleeping, circadian rhythm. Supraoptic is for ADH, and paraventricular is for oxytocin. Preoptic nucleus is for thermoregulation, sexual behavior, and GnRH. There is a problem called Kalman syndrome, with this failure of GNH producing neurons to migrate from olfactory pit. Coming to thalamus, very easy. Ventro-posterior lateral nucleus. V for vibration, P for pain, pressure, proprioception, L for light touch. All these are carried to the primary somatosensory cortex in the parietal lobe by spinothalamic and dorsal column or medial lemniscus. Next, coming to ventro-posterior medial nucleus. V for here not like that, but here it's face sensation and gustatory taste pathways take them to primary somatocortex, that is in parietal lobe. Next, lateral geniculate nucleus is cranial nerve 2, that is our ophthalmic and optic chiasm, optic tract. They take senses like vision to primary visual cortex, which is in the occipital lobe. Medial geniculate nucleus is superior olivary and inferior colliculus. This takes hearing to primary auditory cortex, which is in temporal lobe. Ventral anterior and ventral lateral nuclei is taken by basal ganglia and cerebellum to the motor cortex in the frontal lobe. Now coming to limbic system. So limbic system is collection of emotion, long-term memory, olfaction, behavior modification. So it consists of hippocampus, amygdala, mammillary bodies, anterior thalamic nuclei, cingulate gyrus. Also contains entorhinal cortex. It is responsible for 5 F's, that is feeding, fleeing, fighting, feeling, and sex. Now coming to dopaminergic pathways is very simple thing. Only mesolimbic the activity will increase, in all other pathways activity will decrease. So here you can see easily this is the mesocortical pathway. Mesocortical pathway begins in the this one, mesocortical pathway, this one, it begins in the ventral tegmentum area and goes all over the cortex. Next, coming to mesolimbic pathway. Mesolimbic pathway also becomes in ventral tegmentum area and it ends near nucleus accumbens. Next, coming to nigrostriatal pathway, LO1. It also begins in substantia nigra and ends in dorsal striatum, hence the name nigrostriatal. Next, tuberoinfundibular begins in pituitary and goes to thalamus. So, tuberoinfundibular. Remember, in tuberoinfundibular there is rise in prolactin, but the activity is low. In everything activity is low, only in mesolimbic activity is high. Now coming to cerebellum. Cerebellum is called as little brain. You know, this is the vermis, these are the lateral parts, lateral hemispheres of cerebellum, and this is the flocculonodular lobe of cerebellum. So there are different nuclei, deep nuclei, which are arranged in cerebellum from lateral to medial. So lateral to medial, DEG F, D dentate emboliform globus vestigial. So it's from lateral to medial, and they modulate mainly coordination and balance in our body or the cerebellum. So if there is some problem in the lateral side, and one more thing very important, there's ipsilateral loss. So for example, if right side of cerebellum lobe is lost, then right side only will get the problem. So it's ipsilateral one. So there are 2 cerebellar inputs and 1 cerebellar output. 2 cerebellar inputs. First one is middle cerebellar peduncle, which is coming from contralateral cortex. Next one is inferior cerebellar peduncle, which is coming from the spinal cord. And the output is superior cerebellar peduncle, which goes to contralateral cortex. And here for the flocculonodular lobe, the input and output both are vestibular nuclei. Okay, so whenever there's any lesion in the lateral part of the cerebellum, then it will affect the same side of the leg or the same side of the body part. Whereas medial lesion, this one medial part, the medial lesion will lead to ataxia, wide base gait, nystagmus, head tilting. So that will lead to bilateral motor deficits if the medial structure has lesion. So we test by rapid alternating movements, like we said the patient to bring the finger to the nose, or we say to bring the heel to shin, or gait, we look for the gait. And we also, important thing is intention tremor. Intention tremor is seen in cerebellum, like if we say them to do some work, then they start tremor. But from the beginning. In the rest also, if they have tremor, then that is basal ganglia problem. So this is how we can differentiate cerebellum from basal ganglia. In cerebellum, if they do any work, only then they have tremor. But in basal ganglia, from the beginning, even if they don't do any work, also they have tremor. That is basal ganglia problem. So we have come to basal ganglia. Basal ganglia have two pathways, direct pathway and indirect pathway. Direct pathway is by D1, indirect pathway is by D2. Remember that direct pathway will increase the action, indirect pathway will decrease the action. So direct pathway, the mnemonic is MCIT, that is from the motor cortex to the striatum to the globus internus to the thalamus. So this is MCIT, this is direct pathway which increases the action, whereas MCIT is for the indirect pathway which decreases the action, that is motor cortex to striatum to globus pallidus externus to thalamus. And remember that Huntington disease is MCIT pathway, that is direct pathway, because in Huntington they have chorea, they have abnormal high movements, purposeless movements, so that is MCIT. Whereas in Parkinson disease there's MCIT, that is globus pallidus externus is affected because there's very low movement. These patients are having shuffling gait and they're almost bedridden, so that is Parkinson disease. So this is about basal ganglia. One more thing, striatum is equal to putamen plus caudate nucleus, dentiform is equal to putamen plus globus pallidus. Now coming to cerebral cortex, we know we have frontal lobe, parietal lobe, occipital and temporal. In frontal, frontal lobe is for motor, basal ganglia and cerebellum all bring to the frontal lobe for the motor function, like for the action, for the movement. We need this frontal lobe, and we also have Broca area in frontal lobe, which is important to remember. Also you have frontal eye field, which is whenever you have lesion on the brain lesion side, eye moves in the frontal eye field. Okay, now coming to parietal lobe, parietal lobe receives it's a somatosensory cortex. It's receive many input like light, temperature, proprioception, pressure, vibration, everything. In parietal lobe, you have Baum's lobe. So when Baum's lobe get damaged, you get quadratic anopia. That is, you see towards the down and out. Same like third nerve palsy. Occipital lobe, it's for hearing. Occipital for vision, temporal for hearing, and in temporal lobe there's Mayer's lobe, which the eye looks up. That is quadratic anopia. Mayer's lobe is in temporal lobe. Okay, now coming to cerebral perfusion, there's a formula called CPP is equal to MAP minus ICP. And one more thing is this intracranial pressure, decreased blood pressure or increased ICP lead to decreased cerebral perfusion pressure, and that will lead to Cushing reflex, where there's a triad of hypertension, bradycardia and respiratory depression in response to high ICP. So whenever you have high intracranial pressure, then you may have chance to get Cushing reflex, which have hypertension, bradycardia and respiratory depression. Okay, therapeutic hyperventilation is a treatment for them because there's decreased PCO2 that will lead to vasoconstriction, and because of that there's decreased cerebral blood flow, and that will lead to finally decreased ICP. So PCO2, low PCO2 and vasoconstriction is the answer for decreasing intracranial pressure. So this formula is important. CPP is equal to MAP minus ICP. If CPP is equal to 0, then there's no cerebral perfusion in the cases like brain death, coma, because there's absent brainstem reflex and also apnea. Now coming to homunculus, very simple. Anterior cerebral artery, middle cerebral artery, posterior cerebral artery. Anterior cerebral artery supplies your lower extremities. Middle cerebral artery supplies your hands, face, and posterior cerebral artery supplies especially eyes. So the same homunculus, anywhere you see anterior, middle, posterior, anterior, middle, posterior, anterior, middle, posterior. So there are some watershed areas like ACA MCA watershed infarct will cause upper and lower extremity weakness, that is man in barrel syndrome, because ACA MCA both are affected, right? So ACA means upper limb and MCA means lower extremity, in between them. PCA MCA high order visual dysfunction because PCA is there. So circle of Willis, this is anterior cerebral artery. Both anterior cerebral artery fuse together to form anterior communicating artery. This is the middle cerebral artery. Both middle cerebral arteries communicate together to form posterior communicating artery. And this is the posterior cerebral artery, which have three branches: superior cerebellar, pica, and basilar and vertebral artery, and also its branch anterior spinal artery. So now coming to dural venous sinuses. So dural venous sinus, one thing you need to understand is the CSF whichever is present in our brain drains into dural venous sinus, and from dural venous sinus it directly goes into internal jugular vein, and there are arachnoid granulations which absorb the CSF and give it to dural venous sinus, and dural venous sinus take it to the internal jugular vein. So this is the flow of drainage of CSF finally into our blood vessels. Now coming to ventricular system, we know the ventricular system, lateral ventricle to third ventricle to fourth ventricle, and fourth ventricle finally to subarachnoid space. So how it goes? There are some foramens like two lateral ventricles drain into a third ventricle by means of foramen Monro, and from the third ventricle they drain to cerebral aqueduct, right? Cerebral aqueduct. And next, from the fourth ventricle, they go into the subarachnoid space from by foramen Lashka and foramen Magendie to the subarachnoid space. Now coming to the brainstem. In the brainstem, just you need to write 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and remember that 3, 4, 6, 12 are in the middle. Remaining all are lateral. And here comes PCA, 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 ICA, ICA, middle, basilar, pica, pica, middle, ASA. So if you draw this diagram, then you'll understand midline are all motor nucleus, motor pathway, medial longitudinal fasciculus and medial lemniscus are related to the medial pathway, and all this lateral. So if you understand this, you can remember which artery, which side, in which part it's got affected. Now coming to brainstem, pineal gland, it releases melatonin and controls circadian rhythm. We have superior colliculi, inferior colliculi. Superior colliculi is for eye movement, inferior colliculi is for auditory purpose. So we'll end part 1 here. Next we'll begin part 2 in another video.